Okay, we're going to finish up here, and that was actually a pretty nice lead-in. We're going to finish up with Luke Wilkins. He's from the University of Virginia, a former fellow from MUSC. And as I mentioned at the very beginning, we sort of changed the title of this, this session from a few years ago when it was just called Embolization. And now that we have other ways to treat bleeding, and a bunch of the other speakers have talked about covered stents and other alternatives, that's what Dr. Wilkins is going to address specifically. Luke?
All right. Good morning, everyone. Thank you very much for the opportunity to speak here today. So when Bain first called me and asked me to give this talk, he said, you know, I'd like you to talk about covered stents, an alternative method to traditional embolization for hemostasis of internal bleeding. I thought, gee, could you just make it a little bit more specific? Because the only way it'd be more specific is if you named an artery and or a day on which to perform the procedure. So I started thinking about it. I was like, God, that's very specific. You know, let me think. What are some times that I've used covered stents? And one of the first things that came to mind was when we're doing a fistulogram. We'll see an area of stenosis, which is flow limiting, and so we'll place a balloon there, balloon it up either to 6 or 7 millimeters, get the waste out of the balloon, and then do an angiogram, and this is what you see. At this point in time, the attending, who's usually watching from the control room, says, please put the balloon back up, and that's what happened, but the bleeding persisted. So you can place covered stents. In this case, Viabons were chosen. The first one landed a little short. It was extended further, and got a very nice result with no evidence of bleeding. And I thought, well, that's all well and good, but I'm not going to get up and talk about fistulograms and placing covered stents in misadventures. So let me do a little homework and let me figure out what other people have talked about on this topic. And so I did a little Google search and saw this paper as a percutaneous transfemoral insertion of a stent graft to repair a traumatic femoral AV fistula. And I thought, oh yeah, we do that. And I noticed, I recognized a couple of the names on that paper. Then searched a little more, again, recognized some names on that paper. And so we do this, and I thought, okay, that's very interesting. We can do these for repair of trauma in the femoral artery, and you search more, and dovetailing on what the previous speaker, we can place covered stents in the carotid. But I thought, you know, surely there are other areas in which we've placed covered stents, and I remembered cases as well. But first we'll talk a little bit about those situations, in the femoral artery and in the carotid artery, and then we'll talk about kind of some more out-of-the-box ways to use covered stents. But briefly, the pros of using covered stents: you can maintain vessel patency. It's minimally invasive, much less cost when compared to open repair. Also much less cost when you talk about using lots of coils. You can do what you may do with lots of coils, but just with one covered stent. Final pro is it's a control of fistulous communication. Certainly there are cons, though. Previous speaker talked about this. You know, can be difficult in tortuous anatomy. Some of the covered stents may be subject to endoleak if you're placing these across a pseudoaneurysm or an aneurysm that may have vessels feeding it. The long-term patency can be an issue. If vessel taper can be a problem and needs to be accounted for. Size limitations, too. Covered stents only come in certain sizes, and so very, very small vessels can be treated with covered stents. And finally, you can lose some side branches and collaterals with the placement of a covered stent. So going through some of these cases, and some of these were very similar to the previous speaker, but we had a 48-year-old man, recurrent bleeding from a tracheostomy site, and he had a CT performed. This case is courtesy of one of my partners when he was practicing in Korea. And you could see that he has a trach in place, and the brachiocephalic is very close to that trach, but we didn't see any, or he didn't see any evidence of active extrav. Brought the patient to angio. Pigtail in the ascending aorta, did an injection. Again, didn't see anything noteworthy, but the trach was still in place. Trach was removed over a wire, and then he saw this. Very large amount of contrast extravasation, pseudoaneurysm formation. And so he put a wire across that, covered stent, no evidence of bleeding following that. Another case, it was a 42-year-old man. He had a remote 10 to 15 year history of a stab wound to the neck, and now he had a pulsatile mass at the scar site. angiogram is performed, the finding is quite subtle. A wire was placed across, covered stent, and got a very good result with nice flow through, and no evidence of continued pseudoaneurysm formation. So kind of starting at the head, those are fairly straightforward ways to use a covered stent. How about in the extremities? Well, we had a 24-year-old man, similar to a couple of Dr. Robeson's cases, a 24-year-old man, status post multiple gunshot wounds. This is courtesy of one of my co-residents who is now practicing in Cook County, and saw a lot of streak artifact related to that gunshot wound, and saw this finding, which is a pseudoaneurysm slash active contrast extravasation slash AV fistula. He got access, took the catheter up to the subclavian artery, did an injection, and you could see a large pseudoaneurysm, a lot of contrast pooling adjacent to that artery. You could see rapid filling of the vein, and you could see small tapering of the artery distal to the point of injury, so consistent with AV fistula. Images further down showing extensive communication with the venous system and extensive tapering of the vessels down the upper extremity. You got a wire across, place a covered stent, no evidence of further bleeding, no evidence of venous filling, and the vessels going down the arm, again, are much better filled. So another area where I thought, we place covered stents in this situation as well, similar to when we're doing a fistulogram, you may balloon an area which is heavily calcified, in this case a 4x10 Mustang, and after you PTA, you do your follow-up, you see 2 areas of active extrav. Again, this can be treated with a long Viabon with good result. 44-year-old man, status post a heart cath, pulsatile mass in the groin. Ultrasound showed findings consistent with a pseudoaneurysm arising off the profunda. Given the size of the neck and given the location, thrombin was, we did not elect to inject thrombin into the pseudoaneurysm. Instead, we got contralateral access, wire and catheter up and over, did an injection, and saw a very large pseudoaneurysm arising from the profunda. But on the basis of this imaging, when you're injecting from the common femoral or from the external iliac, it's very difficult to tell where exactly the pseudoaneurysm arises. Does it arise off the profunda itself? Does it arise off a branch? Is it a portion of it being fed by the SFA? It's kind of hard to tell. And a catheter was then placed in the profunda and injection performed, and here you can see the hole within the artery that then gradually fills with more contrast. So you can tell it's coming off of a side branch of the profunda. So it's not actually coming off the profunda itself. So some people might say, well, why don't you just coil this off? There's some arguments for that. However, in this instance, we elected to use a covered stent. And another argument might be, well, that covered stent's in a very, very tiny vessel, and that will eventually go down. And yes, it probably will. But until then, until it goes down, he has time to develop collaterals around it. It's much easier to tolerate this than to tolerate a complete embolization of that vessel. One final case in the lower extremity is a 63-year-old man. He was a status post a left knee replacement redo. They were replacing a spacer, and it was complicated by massive bleeding, quote unquote. They emergently called 2 vascular surgeons who opened, and they were unable to be repaired by a cut down and exposure. So they placed a tourniquet up, and that allowed the bleeding to kind of slow down. Got an ultrasound, very, very pretty image of a pseudoaneurysm behind the knee. Patient was brought emergently to angio. And angiogram down the left lower extremity showed it's very difficult with the knee replacement to see exactly where the pseudoaneurysm is coming from, but you can tell it is coming from the popliteal artery. A wire and catheter were used to cross that area, which was quite a feat in and of itself. And a Viabon was placed and then post-dilated. Here is our before, and here is the after. So again, these are all fairly straightforward cases where covered stent makes sense. But what about cases with a little bit more challenging anatomy, like visceral vessels? What tools can we use to make our lives a little bit easier when we're in some challenging spaces? Well, just some things that have helped me along the way: some thorough pre-procedure imaging, time permitting, with CTA and multiplanar reconstructions. a detailed procedural plan, knowledge of device compatibility. Nothing is worse than getting access with a wire and catheter and realizing you have the wrong size sheath, and a well-stocked storeroom. So we had a 68-year-old man with abdominal pain and concerning findings on a CTA. And this was his CTA. And here we see a aneurysm arising off the superior aspect of the celiac artery. Now, I agree that his abdominal pain is likely unrelated to this aneurysm. However, the size of this aneurysm was large enough that it did require treatment, and it was at risk for rupture. Of note, he had a left gastric artery arising immediately adjacent to that aneurysm, so I knew that that was going to have to be embolized prior to placing a covered stent across the celiac artery. So again, thorough pre-procedure imaging, trying to make sure that you have a plan, make sure that all your devices are working together. So I decided, measuring the splenic artery, I'd use a 10 millimeter Amplatzer 2, which I knew went through a 5 French sheath, and I was going to place a covered stent all the way from the common hepatic artery across the splenic origin, across the aneurysm, to the proximal portion of the celiac. And so distally, I thought I would use a 7 millimeter Viabon, which goes through a 7 French sheath when it's on an 018 platform. But going back into the celiac trunk, I would need a 9 millimeter Viabon, which doesn't come on the 018 platform, it comes on the 035 platform, and that requires a 9 French sheath. So I had to account for that in my head and make sure that, that once we got across, we had all our sheaths and they were all compatible. So first angiogram, again from the celiac trunk. We got a sheath up into the splenic artery. Amplatzer was deployed, and then I saw this, and I knew that this artery, which was the pancreatic magna, would have to be taken care of, or else that would be another source, potential source for endoleak. So I didn't want to embolize the pancreatic magna without making sure that there was adequate collateral flow around. So got a catheter into the GDA, did an injection, saw that there was adequate filling of the pancreaticoduodenal arteries, felt justified in taking out that pancreatic magna with 2 concerto coils. And then got access into the left gastric, which was immediately adjacent to that aneurysm, and placed coils. And now we're ready to place our covered stent now that we've embolized all our potential sources of endoleak. So the sheath was redirected into the proper hepatic artery, and we deployed a 7 millimeter Viabon, and then placed an 8 millimeter Viabon, and then a 9 millimeter Viabon, kind of telescoping into each other. This was finally, you can see the aneurysm on this lateral view here, and the Viabon was then placed. Good angiographic result with no filling of that, no filling of the splenic artery and the other embolized vessels. And on follow-up, the stent was still patent, and you could see the aneurysm is not being filled, has a small rim of calcification. So another case that I was feeling pretty good after that case. I thought, well, that wasn't too bad. I think I can do this again. So we had a 52-year-old man, status post a Whipple. He had a hepatic artery reconstruction, which was complicated by a bile leak, and he had an acute drop in hemoglobin of 4.4. And he had multiple CTAs over the course of the past month, and the only thing that was new about this CTA was that small outpouching coming from the bypass portion, which was consistent with pseudoaneurysm, and this was his likely source of bleeding. Going back to that, if some more astute observers will note that area of increased density adjacent to, anterior to that pseudoaneurysm that I pointed out with that arrow, those were present on the pre-contrast images. This case was a little bit different than the last case, and this is where the thorough pre-procedure imaging comes in. This patient had a replaced left hepatic artery arising off the left gastric. So we couldn't cover the left gastric, and we couldn't embolize the left gastric in this scenario because I wanted to make sure that his left hepatic artery remained patent. So with that in mind, I thought, well, we'll just place the covered stent just right up until the point of the takeoff of the left gastric. However, it was a little bit of an acute angle, kind of a rough turn there, and so I elected to use ICAS because I was afraid if we placed a Viabon in that area, it'd be a little bit more susceptible to kinking. So planned on using 2 ICAS, and I thought, well, we'll do this. It worked so well before. I'll do an Amplatzer again in this one, and I was going to use a 6 or an 8 millimeter Amplatzer 2, which went through a 5 French sheath. So got up, did an injection. And you can tell already it's going to be a little bit difficult. This anatomy is just a shade more tortuous than the other. Again, the left hepatic arising from the left gastric. So could not get a catheter and my sheath to track out to the splenic artery, so I thought, well, that's okay. I've embolized with coils before, I'll just do that. So I embolized with coils, and that worked okay. I should have at this point realized that I was going to have a problem. And did an injection, saw a marked area of narrowing there, and that where the bypass was. And you can see there's a very acute angulation with my catheter. So despite my best efforts, it was exceedingly difficult. Even though I got a catheter across, it was exceedingly difficult, or excuse me, a wire across, it was exceedingly difficult to pass my catheter, and I knew if I can't even get a microcatheter out there, I certainly can't pass 2 ICAS. So I swallowed my pride, and I got arm access. So coming from above is much easier in these types of situations, given the acute angle of the vessel. So sheath got all the way across into the proper hepatic artery, placed 2 ICAS, and our follow-up run, we were able to land those without filling to that pseudoaneurysm and without occluding that left gastric. Well, I had a conclusion slide. I don't know what happened to it. But, in conclusion, covered stents can work great. There are some scenarios where a covered stent makes more sense and is very straightforward. And some of those I saw within the carotid, the femoral artery, those that make a lot of sense. However, when it comes to placing covered stents for embolization, when you're doing in the visceral vessels, it is very important to have a detailed plan and thorough pre-procedure imaging. Thank you very much for your time.